Welcome to this GUcast live event, another of our live webinars supported by our gold partner, Mundipharma. Today, we are focusing on high-risk biochemical recurrence and asking the question, is this really just metastatic prostate cancer? It is coming up on 7 p.m. here on the east coast of Australia. Let's go live now to the GUcast studio and join your hosts, Renu, Eapen, and me, Declan Murphy, plus our international studio guest, Andrew Loblaw, and virtual guest, Jeff Goh. Please vote in our polls and please ask us questions. Enjoy. There you go, Renu.
Wow. Here we are at another live webinar. It's exciting.
We love these live webinar events. Welcome. My name is Declan Murphy, urologist at Peter MacCallum Cancer Centre in Melbourne, joined by my co-host,
Renu Eapen, also from Peter Mac here in Melbourne.
And we are the co-hosts of GUcast, and that's where we're coming to you from, the GUcast studio here in Melbourne.
I'm already looking to my right here because you can just see his arm.
Yeah.
Andrew's in the studio with us.
Andrew Loblaw. So welcome back, Andrew Loblaw.
So great to be here. Thank you for having me back.
Yeah.
I feel like a real seasoned pro now. I know which camera to look at the right time.
He's so slick, isn't he?
Well, we've managed to catch you just in time because you're about to finish your
24 hours.
time in Australia and you're gone. So we get him for another hour.
We should give him a proper introduction. Andrew Loblaw, GU radiation oncologist extraordinaire from Sunnybrook in Toronto. And he's here in Melbourne on sabbatical kind of for a couple of months, but he came into this studio. You weren't here, you left me on my own.
I know. You recovered?
Well,
he fended well though. He fended really well.
Me and 3 radiation oncologists.
Yeah, it was good.
And
sounds like a joke at a bar.
Well, it is. Usually that's the title of the podcast. A urologist and 3 radiation oncologists walk into a podcasting studio. And Renu, get this, and we said it in the podcast. They described themselves as the horses of the apocalypse. Or
3 horses of the apocalypse.
3 horses of the apocalypse.
We're coming for you.
But search GUcast for that one. It's in the feed in the last couple of weeks. But yes, so look, we're delighted to be here, myself, Renu, and Andrew, and we'll be introducing our other guests dialing in from Brisbane in a few moments. But this is one of our series of live events that we've done from time to time. This one's supported by our good friends, gold partners of GUcast at Mundipharma. So they've put all this together. They've done the registrations and the promotion and advertising. So thanks to Amber, Louise, and everybody at Mundipharma for supporting it. We're going to host this from here in the GUcast studio as a live event, so different to our normal thing. So what does that mean? Well, it means people can ask questions and vote in polls and stuff you can't normally do with a podcast. So that's
it's a way to make webinars much more interactive and fun. And you just have to suffer myself and Declan for an hour. That's all.
Plus Loblaw.
We're going to learn new things.
Exactly. Plus Andrew. And we should go now. Let's go and welcome Jeff Goh, who's also joining us for this webinar this evening. Here he is coming onto the stage. Jeff Goh, GU medical oncologist from Brisbane. Well, thanks very much for joining us on this webinar, Jeff. Great to have you.
Oh, thanks for inviting me. It sounds like you're having a lot of fun already. I wish I was there.
We wish you were here too, Jeff.
We could have
I know. Yeah, it would have
got a really good setup there, and wow, okay, totally impressed.
Fantastic.
So we will make do.
Let me tell you, the audience, and thank you to the audience. Thank you for your dialing in from around Australia, or if you're rewatching this on the podcast, thank you very much for tuning in. So the theme tonight is going to be around, it's hormone-sensitive prostate cancer, but we're going to kind of ask the question about this so-called high-risk BCR, this term called high-risk BCR we're getting used to, some management options for that, and how do we manage it? How do us surgeons who look after BCR, biochemical recurrence, get involved? How do us radiation oncologists get involved? And how do we interact with our friends in GU medical oncology? So we've got hopefully a very edutaining, as we sometimes say, a webinar coming your way. We're going to have 3 talks. I'm going to kick off in a few moments. 3 short talks. We're going to keep them snappy. I'll talk first about this whole high-risk BCR thing. What is it? What does it mean? How do we recognize these patients? And how do we separate them out from normal BCR patients? And then we'll stop and have some discussion time. We already have questions I can see on that monitor, Renu. So some people had pre-sent some questions to the webinar, but you can do that as well. Just follow the prompts on the screen there to ask questions. Then Jeff is going to talk a bit about management of high-risk BCR and mHSPC, just some key messages. Then we'll break and have a few more questions and discussion. And then, Andrew, you're going to talk a little bit about the role of radiation in this setting.
I'll bring it home for you.
Bring it home. He's going to bring it home. Not quite home, because we're going to have a few, in case we're still going, we have a few cases that we've loaded to challenge you as well. And some polls. We're going to ask the audience to vote on some of that. Yeah, so that's it. So please do get involved. That's the whole point of these live events, making them different from a regular podcast, is we can hear from you as well, and so on. So yeah, so shall we kick off?
Good intro. Let's kick off. I don't think so. I think it's it's the BCR is an interesting topic. Comes up often in multidisciplinary meetings, and things have changed a lot in the last little while. So
that's the point, I think, isn't it? It's changing, and it's changing from an imaging and a systemic therapy point of view, and also, of course, radiation oncology opportunities. That's what we want to remind ourselves about. So we're going to go, I think, for close to 90 minutes. It's just after 7 o'clock here in the East Coast in Australia, and we're going to run for up to 90 minutes or so. And so please keep your questions coming. I can see a few here already. But Jeff, we'll take you off the stage for a few minutes, and we'll bring on the slides. And I'm going to try and set the scene a little bit on this what is high risk BCR thing and so on.
Go for it, Declan.
Thank you. All right.
We'll take a break.
You just relax. Don't go too far. Let me have a little chat to you about that. And I asked the provocative question, like we did earlier on, when we were doing the promo for this, is this high risk BCR thing. In other words, like the PSA is rising very quickly. There's some high grade features. Is this like already metastatic hormone sensitive prostate cancer if you do the right scan? So that's going to be one of the questions we're going to tackle. Our disclosures are, well, this webinar is supported by our friends at Mundipharma, of course, Gold Partners, but the GUcast partners are all listed here on the screen. We are very grateful for the support we get from all these companies for bringing you GUcast for over 5 years now, and allowing all this thing to happen. And we have a disclosure statement, which I think is available on the webinar platforms as well. We've put together all of this content, and it's very much a GUcast driven thing, along with our friends and guests here on the podcast this evening. So I suppose this is the paper, this paper from 2024, the EMBARK trial, which has really kind of shaken up this scene, or made us have to think a little bit differently, I think, about high-risk BCR, led by Steve Friedland. We've had Steve here in the studio talking about this, and this trial is actually reading out again this weekend. So this paper reported a positive endpoint of metastasis-free survival, but the overall survival endpoint is coming at the weekend at ESMO, and we know it's positive. It's been announced as a positive endpoint already, but we'll wait to see the details. So it'll become an increasingly important topic, I think, for any of us working with localized prostate cancer following surgery, following radiation, and so on. Yeah, there's Steve here in the studio when we spoke about this. So here are the questions I think we should consider. First of all, who are these so-called high-risk BCR? We never used to talk about high-risk BCR. It's kind of a new term. And what are the options for these men? So if we'll remind ourselves, of course, the EAU have set this out very nicely. They've done some nice work, as I'll show you in a moment, about what is BCR and what are the different types of BCR. And it's not a rare thing, is it? This is like at least a quarter of all patients undergoing surgery or radiotherapy with curative intent for localized prostate cancer. It's not a uniform thing. It's very, very variable. Some men are 20 years later with a PSA of 0.2, and they're sometimes worried about it. Our job is to not do anything to them. Others have booming along PSA within months of initial treatment. So it is very, very variable. And when we talk about BCR, we're essentially saying non-metastatic prostate cancer. That's the idea. You're saying it's not metastatic cancer. It's biochemical recurrence. It's only the PSA. But of course, that means, you have to look at what type of scans have we done. And almost all the data on this, and especially in the EMBARK trial, is based on conventional imaging, not on PET scanning. So we're clearly going to talk a bit about that this evening. And there's a wide range of options, including do nothing, depending on the type of BCR you have. So we're going to try and stay updated with some of these options tonight. But first of all, I have a clear idea in my mind about this, but it's actually not that clear in the data of what level is considered to be BCR. I tend to use the AUA guideline, which says following surgery, it's a PSA of 0.2 with a confirmatory level. So it has to be on more than one occasion. And after radiotherapy, we still have this traditional definition, that's Phoenix still, isn't it, of a PSA, and we can discuss that, a PSA going up by 2 above the nadir PSA that it got to. But clearly there's some different interpretations of that, but for the sake of discussion, that's what we'll put up here this evening. And then this whole so-called high-risk BCR, which has only evolved in recent years, actually has two different stratifications. The first one I'll show you is based on what the EAU came up with about 3 years ago when they stratified BCR into high and low risk. And they're showing you here, for example, after prostatectomy, that it's a PSA doubling time of less than a year, or the initial pathology was quite a high-grade tumor. So that distinguishes from PSAs that are going up very slowly, and maybe the initial tumor was all Gleason 3+4 and so on. And after radiotherapy, similarly, the interval to failure is short, like less than 18 months, or the initial tumor grade is very high, as you see here. And the point being with these stratifications is these are patients who are still suitable for salvage local treatment, not systemic treatment. And you'll see why I make that point in a moment. Whereas this other definition of high risk that's come out of the EMBARK trial that I flashed up a second ago is a higher risk group of BCR. So the definition, this is the way I remember it, is a PSA after surgery of greater than 1 and a doubling time of less than 9 months. And I'll show you in a moment why that is a distinct group of patients who are destined for metastases because they don't have them already. And similarly, after radiation, the doubling time, that's the key thing, doubling time less than 9 months. And the point about this high-risk group is that these are usually candidates for systemic treatment. These are the patients who've had surgery plus often radiation, and the PSA is above 1 and the doubling time is short. It's all about the timing of ADT, or nowadays systemic treatment of some sort. So that's the difference in thinking. You have to sort of separate these patients out to think, the first group are more like, okay, we're going to consider salvage radiotherapy or salvage re-irradiation or salvage prostatectomy and so on. The second group are the ones who are destined for metastases, and you're thinking about the timing of systemic treatment. So here's a typical case just to illustrate these differences. A patient with, you might describe this as EAU BCR. The patient had a prostatectomy. The PSA got to 0.2. He had salvage radiotherapy and the PSA came back down. So that is an example of EAU high risk. But now if we look at the same patient again, and not rare is it, his PSA is rising again. And I've written his doubling time here is 18 months. His PSA is now 0.6. So what is this? Well, it's obviously BCR, but it's not high-risk BCR as per the EMBARK criteria, because his PSA is not rising quickly. So, these guys often, it's not a rush. You can often watch these patients for a while, as I'll show you the data in a minute. But now, if you change the slope of that graph, and now his PSA is rising very quickly, his PSA doubling time is 3 months. What does that mean? Well, yes. So his PSA is above 1, he's had radiation and surgery, and his doubling time is less than 9 months. So this is, to my mind, the classic example of an EMBARK high-risk patient. And that's where we've seen significant changes in management coming our way. So that patient, I've just shown you, why are these important patients? Well, it's because that short PSA doubling time is associated with a higher risk of developing metastases as soon. And the role of systemic treatment for this has been uncertain. Should we start ADT now? There's no metastases. Can we wait longer? What type of imaging should we do? And so on. These are the questions that still are with us today. And I just want to show you, I think these are amazing graphs. These graphs that remind us why PSA doubling time are important. And this is from the classic pound data, the original Johns Hopkins BCR data. And when Steve was here in the studio with us, Renu, you remember he set it all out really nicely. Charlie Pound did the original report, but then Steve updated it. And these are classic papers in urology. We should put them on the GU Cancer Journal.
Yeah, I was just thinking that. This is from when? 99?
Yeah, and then updated in
2007.
4 year time range.
Yeah.
Just
exactly. But look at the difference there in those curves. So this is metastasis-free survival. If the PSA doubling time is greater than 10 months, they do great. If it's less than 10 months, look at that. They're all getting metastases really, really quickly. And not just that, but this is prostate cancer specific survival. Same thing. And Steve explained when he was here in the studio how they kind of pretty randomly actually came up with these stratifications of less than 15 months, 9 to 15, blah, blah, blah. But you can see once the doubling time is less than 9 months, these patients tend to go on and get metastases within a few years, typically. So these are the so-called MBARC high-risk patients, because they're at risk of really quite rapid progression. So think about the doubling time. That's the single most important thing. Before we even get to imaging, I think it's all about the doubling time. Don't do an expensive scan the patient has to pay for. Just do the PSA quite often, and you'll often find, a really good management plan.
Yeah.
As I pointed out, though, these so-called BCR papers have all been based on negative conventional imaging. And like this example you see here of the patient with doubling time of 3 months, or let's say it's the one with the doubling time of 3 months, negative imaging, eligible for MBARC. But what if you do a PET scan? And so this is, I suppose, what illustrates to me the question of, is this really mHSPC if you do a PET scan and the PSA is doubling quickly?
It's interesting because you say, what if we do a PET scan? This is what we're doing.
Well, exactly. And in countries like Australia, where PET scanning is funded for this,
exactly.
and that's what's going to happen. There's going to be no conventional imaging. But there's an argument, though, to say, you'll if you have access to and you know how to manage these patients post MBARC, don't bother with a PET scan. Just do the PSA often. Well, let's talk about that. Yeah. I'll wrap this up because there's one paper.
That's my talk.
That's your talk.
That's my talk.
So if you want to drop off later, but I've seen his slides. He's got some very good points and nice pictures. But I just want to show you this paper. I'll finish with this because it kind of answers that question. So this is a really, really nice paper from JAMA Open Network earlier this year. And it answers that question of, what if you do a PET scan in one of these MBARC type patients? So that's literally exactly what happened. This is from UCLA, and this is from 4 different prospective trials, these registration trials that they were running at UCLA over the past few years. And they went back and looked at the patients who would have met the MBARC criteria of, PSA above 1, doubling time less than 9 months, and so on. And you'll see the split there on, some of them were post-surgery, some post-radiation, some of them both both surgery and radiation. And the question is, what do you see in these patients with negative imaging? To give you some idea, what were the PSA levels? It was about 2-ish, 2.8. So, these are PSAs above 1, but they're doubling quickly. And the time point that they had a PET scan is this. It's very similar in the MBARC trial. By the time they go on treatment, it's about the same. So this is the patient who you've been watching the PSA, it's doubling, and before you know it, it's about 2 or 3. So what happens with these are negative scans, remember, what happens if you do a PET scan? I mean, we all kind of know the answer, but this is the first time we've seen good data on it. Overall, what you see is 83% of patients, crazy. You see something on the PET
scan.
Not
crazy, but like it's really impressive, right?
Well, it is. That number is quite amazing.
83%. But they're not all metastases.
They're not all mets.
Some of them are in the prostate if you've still got radiation, or they're local recurrence. But it's still, you go from normal scans to now 83% chance if we do a PET scan in these patients, we're going to see a PSMA avid lesion. And that'll be, Andrew's going to talk about that, in a short while, because that clearly opens up options. Or what you'll see, I'll show you in a moment, is that overall the proportion of patients with metastases, I think, is 35%. There's more details. It's down along there. So overall, it's 35% are M1, they're mHSPC. So that if you had done those scans in Australia, then suddenly you have the options of mHSPC options, because here we don't have to, in Australia, we can use doublet therapies for these patients if they're metastatic on a PET scan, even though they're non-metastatic on conventional imaging.
I think it was half that had pelvic lymph nodes, if I remember that.
About half.
About that.
Exactly.
So like 25, and about half.
That's right.
Pelvis, if I can remember.
Yeah, but a fair chunk of them have bone metastases as well. If I can see what it was like 20% or something like that. 25% of bone metastases.
If only we had a treatment that would actually.
Stay tuned. Yeah, so look, there you go. You can take my slides down off the stage, Chetna, and we'll bring Jeff back up. So that's really what I wanted to do, was set the scene to say, look, that's what we're talking about with these so-called high-risk BCR patients. And, what we want to do is understand the management options, but also consider what if we did a PET scan. So Chetna, you can take my slides down, please, and bring Jeff back onto the stage, if you can hear me. And we'll have a quick chat about that and see what we make of it all. Yeah, but what's your reaction while the tech team are trying to sort that out?
Yeah, it's interesting, isn't it? Because I think there are a few dilemmas here. I mean, the post-surgery pre-salvage radiation population is interesting, because if these patients have high-risk BCR, do we treat with salvage radiation, or do we treat systemically, or do we do a combination? I think there is a kind of a conundrum there.
Yeah.
Those who've had salvage radiation as well, I think the decision is a little clearer. Because the next thing is systemic treatment, and the main question is, well, when do we treat? Do we treat now, or do we wait? And, you know, when we don't have doublet therapy funded for BCR setting, you know, things like PSMA PET CT might show up a lesion that makes them mHSPC, and then we can treat them with doublet therapy.
Yeah.
So, but those patients in between surgery and salvage radiation, for me, they're the tougher cases.
Yeah, I think it all depends on doubling time and the patient that's sitting in front of you, right? So you got a guy who's had surgery 10 years ago, his PSA is like 0.3, going up like doubling every 2 years. That's not a guy you're worrying about, right? Like I could give him radiation treatment, but maybe there's some benign glands that are just growing back a little bit. Like I had one guy who grew back his entire prostate 15 years after treatment. Probably didn't have a radical prostate, but I'm just saying it does happen from time to time. Then you get these other guys, these young guys, fast doubling times. Those are the guys you worry about. You want to get on them early with salvage radiotherapy. I think there's fairly good data that you don't need to do adjuvant on everybody, but early salvage does make a difference, right? So you don't want to wait till 1 or 2 or 3 before you're sending them off to the rad-onc. And then again, I think what's going to change everything is the PSMA. Like now that I actually know a lot of people who won't offer salvage radiotherapy or refer them in until they actually have a PSMA positive disease.
I agree, and then you lose that window, right? That's a bit of harm that PSMA PET has done.
So we'll always stay in business. Yeah. There are always 2 questions to answer.
We have a few questions. Jeff, you're tuned into this as well. Some of them are just, you said, and a lot of them is about the imaging already, as you might understand. Thank you, and please keep sending your questions in. Not everyone's got a name on it. Some of you have named yourselves, but here's one. What imaging modalities best distinguish local BCR from metastases? Andrew, I might ask you that question. I suppose they're talking about, okay, should we be using MR, for example, to look at these? Because we used to do a lot of MR when we're planning salvage radiotherapy, for example. So
yeah, my perspective has changed, Declan. So we used to reach for our MRIs first. And now that we've got access in Canada to PSMAs, that's our first play. That's our first card on the table. And then if we see localized disease, we want to characterize that a little bit better. And that's when we pull out our multi-parameter MRIs, particularly if we're thinking about some local salvage therapies, whether it's salvage for radio-recurrent disease, if like we're giving radiation a second time, or we're thinking about salvage surgery or some sort of ablative therapy, or whether it's a post-op. We don't tend to use MRIs very much in the post-op setting because you guys tend to send them in quite quickly. So it's like 0.1, 0.12. We're not going to see anything. But if it's 1.5, there may be a nodule there for sure.
Yeah, I guess in Australia, I think we've got a reflex action that we reach out for the PSMA PET in the first instance, isn't it, really? I think now that it's funded, I think it's really kind of fairly straightforward to order. Access to it is quite easy as well in Brisbane. I'm not sure about Melbourne. I'm sure it is quite easy. Yeah.
Jeff, while you're on the line, another question is about, the patients with negative conventional imaging. They happen to have it, but then occult kind of metastases that you now see on a PET scan. Do you always reach then for metastatic options, or do you still trust the conventional options, which is defined, I suppose, all the literature that you like to use?
Yeah, well, I think that's a good point. I think it comes back to the aggressiveness of the disease, doubling time. You've made a very good point about the less than 9 months doubling time. I think that really predicts for really bad outcomes. So I think with those patients with a bad doubling time, and they're going to relapse, systemically. So I think I would certainly reach out for systemic options and use my PSMA as the basis of an RP, really, in combination with ADT. Yeah.
We'll do maybe 1 or 2 more before we ask Jeff to do his talk. Renu, here's one from Abdullah Al-Kanati. You know that guy?
Oh, yeah. That name rings a bell.
I know him, one
Hi,
of our
Abdullah.
talented young unaccredited registrars. Abdullah asked, has PSMA PET redefined what we even mean by BCR? And are we now over-treating biologically indolent disease detected earlier than ever before? So, maybe I'll give you a scenario. A patient who's not high-risk BCR, he's got BCR, but it's 4 years later and the PSA has just about reached 0.28 or 0.3, and, it was originally decent 3+4 sort of cancer. But you see something on a PET scan, like a bit of local recurrence, Is it possible that we, you know, the novel imaging might tempt us into doing extra treatment? Maybe that's the question.
Andrew. I'm like, you pass it down, I'm going to determine all this.
Well, we're talking about.
Well, he's going to just radiate it.
That sounds like a piece 5. That sounds like a piece 5 question, right?
Well, it's actually,
yeah. So it's like, you know, there's data that was presented. It's not been published in, I think, Lancet Oncology. Yeah. Basically showing, do you just do spot therapy, welding, or do you do whole pelvis and spot therapy? And the data suggested that biochemically, you did a better job from a PFS point of view if you gave a whole pelvis a wash and gave a little extra deuce, shot a few more bullets into the bad guys. And there's a trend to an MFS as well. So I think with more time, we're going to see that study read out and maybe change things. And it really just opens up a bunch of questions for us. Like now, that was all pelvic disease post-surgery. What do we do for periaortic disease? What if it's above the diaphragms? Like, can we treat with shorter doses of treatment? Because that was a 25 treatment program for the whole pelvis. Can we do it in 5? We know that's well tolerated and that's better for patients. So there's lots of questions. That's the great thing about research is that as soon as you get one answer, there's like 10 more that comes down the pipe.
Shoot the bad guys. Did he say shoot the bad guys? Is that what the way they talk?
Yeah.
Okay. I like the bullet analogy. The surgeons understand the bullet analogy.
Mr. Jones, you got a few bad guys we can see on a PET scan.
Yeah, we're getting to fire some bullets out.
The PokeMet thing doesn't, you know, it's not, the shooting seems better.
I love it.
A great question from Jonathan Walbaum here. What should we do with embark high-risk BCR with negative PET PSMA? So this is, I think, a situation we often confront in the MDT. These patients have high-risk BCR and fits the criteria. PSMA PET is negative. So it's, you know, it's non-metastatic. How do we treat these patients? When do we start treatment? I don't know. Maybe Jeff, you'll cover it in your talk a little bit.
Look, that's a tricky area, I think. I think, you know, first of all, you really have to have a good discussion about ADT with this patient, and then you try and source the enzalutamide really from Astellas. Hopefully, I think they're applying to the TGA as well as the PBAC for funding. So hopefully the data will be strong enough for everyone with high risk BCR to actually get enzalutamide really. But that is 6 months away, I think.
And Andrew, what if these patients have not had salvage radiation in their post-surgery?
I think salvage is the easiest gun to pull. And for those patients you worry about more, I would add an ADT to the situation. I personally like 6 months. I know the radicals HD was a big question that people, but I think with DAD stop meta-analysis, I think we're seeing 6 months is kind of the sweet spot because we all know the effects of these hormones on patients. You know, long-term hormones, it really knocks the stuffing out of them.
Absolutely.
Well, look, that seems like a good time to go to Jeff. And Jeff, we'll hand over the stage to you. You're going to chat to us a bit about systemic management options for BCR/mHSPC, which is what we're talking about. So over to you in Queensland. And we have more questions. We can see them here, and please keep them coming. Thank you.
All right, I will advance the slides. Right, okay, that's me. Can you see the screen? Okay, so that's me. I work part-time as a staff specialist at Royal Brisbane and Women's Hospital, and also privately at Icon Centres and Greenslips Private Hospital. So those are my disclosures, and that is another disclosure statement that you've seen before earlier with Declan's slide. I'll just let it sit for a second or a few seconds. So we know that the patient journey is such with prostate cancer, and we're talking about really biochemical recurrence, which is at a midpoint, the transition between the patients being with the urologists and before they are being handed over to us, medical oncologists, which is kind of a time which is gradually being defined, and it's becoming earlier and earlier. In the past, we never used to get the patients until they're castration resistant, but now we're getting in very early with any signs of metastatic disease in the CSPC setting, because we have four RPs that are funded in Australia for the treatment of HSPC, metastatic HSPC. So we are, thank you, and the new urologists are even studying patients on RPs and then sending them across to us, which is fine as well. I think my sort of priority is to make sure that patients get the best standard of care available, you know, in Australia that is funded to improve their long-term outcomes. So that's my focus. So PSMA PET, Declan's spoken about it. It really has greater specificity and sensitivity for metastatic lesions compared to conventional imaging, and it's our preferred modality of treatment. And it's been recommended by the AUA since 2013. If it's available, use PSMA PET CT over conventional imaging. I know the trials and the historical trials that have been done has always relied on conventional imaging, and it's going to be a paradigm shift with trials when we move to the new prostate cancer working group 4, which incorporates PSMA PET imaging into the measurement of progression or response to treatments. In terms of the FDA, again, I think radioligand therapy is also coming to the fore, and therefore PSMA PET imaging is more important from that point of view. So with regards to biochemical recurrent castration-sensitive disease, Declan's gone through those definitions already, and I wouldn't belabor it, except to say that the doubling time of less than 9 months is critical, and the appearance of PSMA PET lesions on the scan actually portends to metastatic disease, and we have to take that quite seriously. Oh, I can't forward it. Can someone help me? Okay, I'm stuck with this slide. Can you forward it for me? Thank you. Oops, sorry. Yep. So the EMBARK trial was first published in October 2023 in New England, and it's a trial of enzalutamide and ADT versus ADT alone for BCR disease, which the definition Declan has actually mentioned with the doubling time of less than 9 months with high risk features. The metastasis-free survival, which is basically a surrogate for overall survival, showed that Enza plus ADT improved MFS to 87% versus 71%, with a 58% risk reduction throughout the life of the trial. The overall survival was also in the early cutoff, 92 versus 87%, a 5% difference. That was preliminary with a hazard ratio of 0.59. Obviously, with the addition of enzalutamide, there are more treatment-related adverse events, and the rate of discontinuation doubled as well. But we've learned how to use enzalutamide well in 2025, and a lot of the toxicities can be minimized with dose reductions. Another interesting arm was the enzalutamide alone arm without ADT versus ADT alone. The 5-year MFS was also improved to 80 versus 71%, but the overall survival was similar. Therefore, I suppose it is not the best option. Next slide. This is the curves from the Legend publication showing the MFS for Enza plus, the print's small, plus leuprolide versus leuprolide alone, and then the bottom graph is enzalutamide monotherapy versus leuprolide alone, again showing a spreading of the curves, which is quite durable. The other point that I'm making is that most of the endpoints on this trial were leaning towards the positive side, towards the benefit of the combination of ADT and enzalutamide. And we can see there most endpoints were positive. So as of the 10th of July, the final survival data was presented as a press release, showing that EMBARK will show a statistically significant and clinically meaningful improvement of overall survival, and that data will be presented in the next week at ESMO. So it also showed a favorable trend towards improved OS for patients treated with enzalutamide monotherapy versus ADT. So in terms of metastatic hormone-sensitive prostate cancer, we've had a long a decade of trials showing initially showing some benefit. The first trial that showed benefit in systemic treatment with ADT in early metastatic hormone-sensitive prostate cancer were the, if you like, STAMPEDE C, and before that charted that Chris Sweeney presented that showed the benefit of chemotherapy in addition to ADT in high volume metastatic castration-sensitive disease. And then there was a number of large phase 3 trials, starting with Latitude, STAMPEDE G with abiraterone, Arches, Enzamet, and then subsequently Titan with apalutamide, showing similar benefits in terms of improving overall survival with the addition of an ARPI to ADT for even early metastatic castration-sensitive prostate cancer. But I would have to put a caveat in that those trials were done using conventional imaging. With PET imaging, I guess it's even more sensitive and specific. So in Australia, I suspect we're using RPs much earlier based on a PET scan. And then there are obviously the more high volume, high risk disease that we would consider triplet. The ARASENS trial showed significant improvement in survival with the triplet treatment of darolutamide, ADT, and docetaxel. And prior to that, the PEACE-1 showed a benefit with ADT, docetaxel, and abiraterone, plus minus radiation in subgroup analysis. So certainly in the hormone-sensitive setting, we have a myriad of choices in terms of RP in combination with ADT for treatment of metastatic castration-sensitive or hormone-sensitive disease. So my take is that in high-risk BCR is getting quite close to the treatment of metastatic hormone-sensitive prostate cancer. However, high-risk BCR definition traditionally relies on conventional imaging, but that is changing with PSMA PET, CT scanning in Australia particularly, being sort of overriding and replacing conventional imaging in most of our practices, and therefore we're detecting M1 CSPC much earlier. So there is really a state shift and an early use of RP and ADT combo, and in some high-risk patient, a triplet combo. There are more choices of RP and ADT combos in the CSPC setting. So for medical oncologists and neurologists in Australia, there is a temptation to just lean on the PSMA PET imaging and call it M1 CSPC rather than BCR to get access to the RPs that are funded. As you know, if you're strictly BCR with no imaging evidence of metastasis, we can't get PBS-funded access for an RP or enzalutamide for that matter in Australia. So we have to wait for the TGA approval and funding in that setting if we're considering using ENZA in the BCR embark setting. So that is probably the end of my section. So back to you, Declan.
Wonderful.
Yeah,
that was awesome, Jeff. Yeah, look at that's a sneak preview to Andrew coming up shortly. Please take that off the screen, Chet, and it's too distracting. Yeah,
Fantastic.
awesome. Thanks so much, Jeff. That was a fantastic overview of these systemic options. So, and how things have changed over the years, Renu, because this whole discussion was about, okay, it's ADT monotherapy for your BCR, how, when, and blah, blah, blah. Is before we even hear about, the use of metastasis-directed therapy. But yeah, great overview, including the embark stuff, of course.
Yeah, and I'm reminded about a moment we had with Steve Friedland here in the studio when he said, embark really is a lesson in how to give systemic therapy. It's telling us that now the standard of care for systemic therapy has definitely changed. It's no longer ADT monotherapy. It should be doublet therapy with an RP, and that works in all settings. When you're considering systemic therapy, you should be considering a doublet. I think that's an important message to take away.
Yeah.
So a question about that. You highlighted the BCR embark data, which is only about enzalutamide, of course. That's the only trial that's shown this. So a question has already come in about this. Are all RPs the same? But certainly for this setting, for the high-risk BCR setting, unlike the other settings like mHSPC and non-metastatic CRPC, there are multiple trials in all the agents. But Jeff, are all RPs the same is one of the questions we've had.
Well, certainly the toxicity of the amides are slightly different. I mean, obviously, I think apalutamide is probably just as potent as enzalutamide. So if you did a trial with apalutamide, you'd probably get similar outcomes, but the toxicity profile is probably slightly less. Slightly different, not less. With apalutamide, you'd probably get more incidence of rash. If you use darolutamide, some people could argue that perhaps that might not be equivalent. You know, that's a moot point, still being debated. But I think it's still a very potent amide and potent ARPI. Obviously, abiraterone is an older drug. It has a different toxicity profile, has a high cardiovascular risk score, and you have to take prednisolone with it. So that comes with added cost in terms of toxicity. So I would probably steer clear of abiraterone just because you have to take prednisolone or steroids with it. So, yeah.
Thank you, Jeff. Question, anonymous question. Is intermittent therapy a viable option on doublets? If you've got someone on ADT and an RP?
That's a great question.
It's a great question.
It's actually talked about in EMBARK. Do you want to talk about that?
Yeah, because EMBARK gives us a peek into intermittent doublet, doesn't
it?
But,
let us know your thoughts, Jeff, on that one.
Yeah, look, I think certainly, I think, you know, in patients with risk scores that are not too high, I would, and depends on toxicity to ADT and enzalutamide. I think it is something that is a discussion between me and the patient, and to see if they really could persist with the EMBARK protocol, or whether they would, want to give it a break. Some men don't even want ADT; they just want enzalutamide, and there's another discussion about just having enzalutamide without the effects of ADT. So that is obviously not the best option in terms of outcomes, but I think for some men, not having ADT is actually a very important fact. And in fact, if you give them ADT, they'll run away. So we're perhaps getting some benefit with enzalutamide alone, and not the doublet in that setting. So I think it needs to be considered.
Yeah, because in EMBARK there was a predefined stopping point, wasn't there?
9 months, I think.
9 months. If at 9 months your PSA got to less than 0.2, you would stop. And in the combination arm, I think
like
85% or something.
Yeah, it was incredibly high.
Yeah, so like 85% of people who started that doublet of ADT enzalutamide stopped at 9 months, whereas in the ADT,
we're able to stop.
We're able to stop. That's true. Yeah, we're able to.
Not all my patients want to stop, but most do. They're like, thank God, getting all this stuff.
Yeah.
Oh, you were involved in EMBARK.
I wasn't involved, but I've adopted it very early, and
okay.
people love the systemic intensification concept. And for a public healthcare system like Canada, it's really great because you're off drug for a long period of time and it doesn't cost much money.
Jeff, 2 quick questions before we ask Andrew to speak. So the first is from Abdullah again. Jeff, are we moving towards a systemic first paradigm in some of these high-risk BCRs after surgery, where you do the systemic even before radiotherapy? Or do you still think, consolidating with radiotherapy to the pelvis, with a question for Andrew as well, is it tempting just to go straight for it if like the PSA is going up quickly? That's always that question, isn't it? About
that's interesting.
Yeah,
I think about the cost of ADT in terms of side effects, and also enzalutamide. There's also the physical dollar cost of it. We actually did Decil high cap, didn't we? I mean, for those high risk patients in Australia. So I'd be interested to see what Decil high cap actually shows. But certainly, I would try as much as possible to try and delay the start of ADT with enzo as much as possible. But certainly, radiation, Andrew can speak about that, but has also toxicity costs. So, and then patient preference has to come into play. But the EMBARK data is so attractive, and that point about stopping at 9 months if they get to a PSA below 0.2 is so attractive, and then you can always re-challenge them, right? That nothing's lost. It seems like there's no loss in survival if you did that. So it's very tempting to start and stop, and do intermittent. I'm very tempted.
So Renu and Jeff, there's another question for you, but Andrew, on that one, so what about these men with BCR after a prostatectomy, but it's like really high risk already? The PSA is 0.9, and then you repeat it 6 weeks later, it's 1.8.
Right.
And negative imaging, we know the data on postoperative radiotherapy means that higher that PSA is, the less likely you're going to have success. So I think that's kind of the question is, look, is there any point pouring radiotherapy into the pelvis when the PSA
Yeah,
is
so I think
going
that's
so
that's a
quickly?
really good point, Declan. I think, we do know that the chance of radiotherapy curing a patient, and I just want to go back to the emphasis of like, radiotherapy is the second chance of cure, right?
Yes.
Like, whereas MBARC or all these other strategies can control disease for a long period of time, but we're really not curing them. We're just putting patients into remission, and hopefully they'll live their entire life and die of other causes. But if you get, so it is uncommon, I think in my experience, certainly I think in your experience, like to get that patient where it's like 0.9 post-surgery and that's doubling like every 3 months. It does happen, but it doesn't happen very often. The most common story I see is like positive margin, slowly rising PSA. It was 0 and it's like 0.05, 0.1, 0.15. And that's the guy I want to do radiotherapy on, because again, what's the chance of high levels of toxicity, serious toxicity with radiotherapy? It's like 1%.
Yeah.
What's the chance of toxicity with enzalutamide? 50%. So grade 3 toxicities are very different between these two modalities, and one's lifetime therapy potentially on or off, and one is potentially curative. So don't throw us out yet.
Yeah,
Don't throw
you're
us
right.
out.
It is. You do have a window to salvage these patients, and I think it's important that we don't forget that, especially in the PSMA PET era.
You were
Yeah.
kind of raising an eyebrow though when you said 1%. Or were you feeling
I was just
Was it
thinking
your
about
bad
I was just thinking about my radiation cystitis patient from this morning.
I must see all those 1%ers.
I don't know what you guys are doing in
I-
Australia here, because we don't. It must be the air. It must be the northern air. in Canada.
It must be, yeah.
All kidding aside.
Something.
I just think about the number of patients I refer to hyperbaric treatment, right?
It's all right. And look, we're very aware a lot of patients watch replays of these podcasts and get that. And we've done a dedicated episode on radiation cystitis recently, which was really, really good. And that was fantastic to see. So, now, Jeff, one more for you. Jeff and Renu. This is a question from Abdullah. Looking a few years ahead, do you see a role for neoadjuvant or peri-salvage lutetium PSMA? So I suppose sort of a neoadjuvant adjuvant sort of approach in the BCR setting. Or will the combination approaches will always still reign? So so it's good. Well, you've just done a PhD on that with the lutectomy trial. She got a PhD today.
Oh wow, Doctor. Hello,
Dr. Eapen. So looking a few years ahead, is radioligand therapy going to be in the high risk BCR space?
Look, I think it has potential, and I mean, when we looked at it in the lutectomy setting, which was neoadjuvant treatment before surgery, the whole purpose was to reduce the biochemical recurrence and improve long-term outcomes. And we know that it has an effect on PSMA positive tumor cells. It has a direct cytotoxic effect, and so I think it has a role to play in treating either occult metastases in this high risk BCR setting that could otherwise be metastatic hormone sensitive disease. I think it will.
I think you're keeping me there because I think I'm actually talking about that. That's one of my
Perfect.
All right, well, let's do that. Jeff, thanks so much. Go and have a breather there. We'll take
mention one
Jeff.
thing quickly?
Awesome, but don't
Thanks,
go
Jeff.
away. We have more questions for you. So let's bring the slides back up, Chetna, and we'll ask Andrew to talk to us about radiotherapy. Andrew, I'll control the slides for you over here. So tell us about this opening image, first of all.
I think you like the gun more.
Yeah.
What is
It's
this?
the
It's like a
gun,
magic
isn't it?
8 ball or
So
something?
Shankar has inspired me to start using AI for
This is
some
your
of the.
sabbatical learnings, right?
Yeah, I started a little bit before this, but this is Dr. Strange with his glowing radiotherapy orb. So maybe I should get the shooting
Very
bullets
cool.
analogy,
I think
but
so. Yeah.
We're harnessing the power of the sun
And is
to
that
cure cancer.
Yeah.
I love it.
Perfect.
Feel it?
Love
Feel
it. I do. I
Feel
do.
it? Feel it.
Definitely
Right.
feel it.
So let's go to the next slide, Declan. So this is our disclosures. I think we already went through that. So we're going to talk about both molecular imaging. We've talked a lot about this, and Declan, you set the stage very nicely on this. And then we're going to talk about conventional imaging. Basically, what is the role of radiotherapy? Is it a triple therapy, right? We've talked about doublet therapy. Can radiation actually add value to the ADT plus or minus the ARPIs or AMIs that we're doing? Next slide. So essentially, the Will Rogers phenomenon, everyone's probably heard this analogy. It was when people from Oklahoma moved to California, the IQs of both states were raised because only the dumbest people from Oklahoma would move to California. but they were smarter than the Californians. So what does that mean in terms of prostate cancer? Essentially, average doubling time, 9 to 12 months. We talked about high risk being less than 9 months, but it's essentially 3 doubling times for about 3 years if you're going to detect that disease with PSMA versus a conventional imaging. And the same slide we're seeing that Declan you went through is the whole growth study. Basically, if you were to take an EMBARC type of patient and do PSMA PET scans on them, you're going to see disease in 83% of the patients. About a quarter of those would have metastatic disease. Next slide. So, there's been a bunch of studies, and I think the most important thing to kind of take home from this is an area of active investigation, but it really shouldn't be, it's not leading to guidance changes at this stage. We're not at the phase 3 level quite yet, but we're very excited about this area. And so you're going to see lots of really small studies, and a lot of the studies here, I don't want you guys to be critical about this because they're signal-seeking studies. They're small studies looking for an effect to do bigger studies to confirm, right? So you'll see p-values and you're like, oh, that's not actually statistically significant. It's not why the studies are designed. They're designed to see whether we're on the right path and whether we want to keep walking down that path. So the first one that everyone gets excited about is STOMP study. So this is patients with recurrent hormone-sensitive prostate cancer. They all had PET imaging, and they were actually randomized to radiotherapy or surgery in this case actually, or surveillance in this patient population. And their primary outcome was androgen deprivation therapy-free survival with quality of life and toxicity, or what we're now calling adverse events. We're not using the word toxicity anymore. Next slide. And so this is this Kaplan-Meier curve that you see over and over and over again. You're seeing some separation in those curves, not dramatically different. But look at the p-value, 0.11, right? So Renu, would you consider that you're a PhD student, you're a PhD graduate now? Would you say this is significant? We should write the guidelines, write to EUA, change? No. But it's worth further investigation, right? Let's keep going. So next slide. So there's other studies. So now that was MDT or metastasis-directed therapy versus observation. So we all know there's a number of studies that have looked at radiotherapy and hormones, either by themselves or in combination. Every time we've asked that question, it's always been the same answer. Like it's been 30 years of the same answer, which is that the combination is always better than either one alone, right? So Radiosa was a study from Italy. Again, a small study, about 60 patients, I think total, if the screen actually continues to protect. And you can see a progression-free survival advantage, nice separation of those curves. So pretty impressive, like median time to progression 32 versus 16 months or 15 months. So adding ADT, this is no shocker, to metastasis-directed therapy improves our ability to control the disease. Next slide. And this is lunar. So this is what we were talking about, lutetium. So this is like your lutectomy study. So this is a Marquishan study, very similar to a Peter Mac study that's going on right now, still accruing patients.
Right, yeah.
So patients with hormone-sensitive disease, with PSMA-defined disease are randomized to metastasis-directed therapy plus or minus lutetium. And next slide, you'll see very nice separation of those curves. I think what's really nice about this is that everyone, including ourselves, hates to give ADT. The patients don't like ADT. They don't like the side effects of ADT. Lutetium is much better tolerated. And so we're seeing similar effects to ADT alone without the use of ADT. Bigger questions like what's the role of ADT plus lutetium? Those are questions we're going to answer going forward. Next slide. So what about conventional imaging? So we've started a little earlier with the molecular imaging, and now we're going to talk about conventional disease. How do we manage that? What are the trials that underpin radiotherapy and surgery in this patient population? And, okay, so extend. So this is the Chad Tang study. This was a basket study that was done out of Texas. And so mainly, there was actually a whole bunch of different tumor sites. This was specifically prostate cancer that they read out. Most of these patients were hormone sensitive. There's a little dabble of castrate-resistant patients in there. What's important about this study is everybody got hormone therapy. Everyone they're randomized to MDT or not, but they're also allowed to get an AR, well, I call it ARAT, but now we're all calling it ARPIs. If you look at the next slide, you can see a big difference again in, sorry, this is the table 1. So about half of the patients had an ARPI, and about, I think, a quarter of the patients actually were novel imaging. So mostly conventional imaging patients, and about half of these patients getting doublet therapy already. And so what is the value of adding stereotactic radiotherapy to this? Next slide. So again, you're seeing the same kind of curves over and over again, same pattern. We're seeing an effect, progression-free survival advantage, not MFS. We're not seeing OS. These are small studies. They're just looking for a signal. We're chasing a rabbit. And we just want to know if we're going in the right direction. Next slide. But there's hope. That's what the guy's looking to the future.
That's what it was.
That's what it was.
To the heavens.
He's looking at these like,
Yeah.
see the future. So this is Oriel. So this is a study that basically looked at metastasis-directed therapy versus observation. So very similar to STOMP, but there's 2 kind of like sub-questions that come out of this. One was that these were all conventionally imaged patients, but they kind of did a blinded flucliclazone. I can't even say that. So like a novel imaging test, but they didn't let the investigators or the treating physicians see the results of that scan. They went back afterwards and said, if you treated all the disease, how did versus you didn't treat the disease, you got some of it, but not all of it, how did you do? And you can see a massive difference. Bottom right here, you can see a massive difference in progression-free survival.
Yeah.
And the other thing on the left side was they had a molecular signature, like an omic signature that predicted for patients who do better. And now, so that was a bespoke test that was done and developed in Baltimore, but now Artera AI is coming up with a new test that's CLIA certified that we might be able to have access. So in the future, I see like potentially doing scans of patients' pathology digitally, and you'll be able to get either an Artera AI or something similar to that to help us decide who's best, who's going to benefit the most. Next slide. Okay, so this is just a slide to remind us that things are moving very quickly. Even at ESMO, there's new PARPI data that's coming out in HSPC. I think the Amplitude study is showing it read out positive. I already saw on Twitter today. So basically things are moving very quickly. So the question is, what is the role of radiotherapy in the setting of doublet or triplet therapy for these patients? And next slide. And so, we did a lot of different, of similar size phase 2 studies that led up to this study. This is a Canadian CCTG study, PR20 or Platon. So basically, these are hormone-sensitive patients with oligometastatic disease. Everyone had their prostate treated with either surgery or radiation treatment. You're allowed to do both. And then they were randomized to best systemic therapy, so either doublet or triplet therapy, or plus or minus metastasis-directed therapy. And again, you could do surgery on the mets if you wanted. If you felt like it was a bone met and you wanted to take it out, that would be fine. If you wanted it was a liver met, you could cut that liver out. That was completely fine. So that finished a year ago, 408 patients. And so this is the largest and the first of the phase 3 studies. There's a bunch of them going on around the world right now. So this is really what's going to define the management of these patients going forward. Next slide. I think we're getting near the end. Okay. Oh, so this is the underpinning. We were talking a little bit with in Embark about this chance of or this opportunity to do systemic intensification. So as we were working up to some of our trials that I'll show you about in a second, this was our CROP study. So this is patients in a phase 2 study prospectively who got a year of hormones and they got metastasis-directed therapy. And this is time to castrate-resistant disease. So I don't know if you guys remember that SWOG study. Remember that back in the day, right? We called it, I can't remember the actual number because we called it PR8. But basically it was metastatic conventional imaging, and they were randomized to intermittent androgen blockade or conventional. But the time to castrate-resistant disease in that study was 18 months. And we haven't even reached it here at 6 years.
Yeah.
Right? So radiotherapy, maybe sprinkling a little sunshine is a good thing around, right? So more to come. Next slide. So we basically have set that up as a number of different, we're trying to set up like a stampede type of MAMS or multi-arm, multi-stage study to study all these different, so we can actually answer these things in an efficient manner. But basically putting it all together, the combination of metastasis-directed therapy, whether it's surgery or radiation treatment plus androgen deprivation therapy, is better than either one alone. What we're really keen on is adding systemic therapies to the mix. I didn't really have a lot of time to talk about that, but basically we're adding in things like ARPIs. We've got one arm with abiraterone, we got one arm with enzalutamide, we have another one with abiraterone and a statin, and we want to put a lutetium arm in as well. So more work's to come. We're not quite there yet, but I think it's an exciting space. And I think the question maybe we can talk about at the table is like, is this ready for prime time, or should this only be offered in a study?
Outstanding.
Wow.
Fantastic.
Great talk.
Thank you, Andrew. Let's drop this.
Guy, Dr. Strange.
I love Dr. Strange. Thank you, Dr. Strange. Let's drop the slides, please, and bring Jeff back onto the stage. Awesome. That was great. So now we got a few different things to think about. It's not just the timing of systemic therapy, Renu. It's the imaging, and now also what about some metastasis-directed therapy? And we're really talking about radiation. There's not much chance we're going to chop it. Many of these metastases.
It's not wrong to do. It's just I think it's whatever's best for the patient, right? So
awesome. Jeff, any comments about that? Jeff is muted, I think. Is he?
Okay. Sorry.
Yeah.
Very, very interesting data, Andrew. Look, I think the fact that you can delay castration resistance to 6-7 years. That's quite amazing data, and certainly it needs to be proven in a larger phase 3 trial. I think that's going to be really hard to do, but if you do it collaboratively with the Europeans and Australians, we might get it done. It is.
Yeah, we didn't talk about this. There's actually a couple of studies that have looked at ARTO and PCS9 have read out and showing that if you switch patients who have CRPC and metastatic CRPC, and you put them on either abiraterone or enzalutamide plus metastasis-directed therapy, you actually do a better job at actually staving off the progression. And then there's another study from the Princess Margaret Hospital showing that if you're progressing, but you keep them on therapy, you get like an oligoprogression setting, you can actually, again, keep them on drug. And it was pretty impressive. It was like 40% of patients 5 years later were still on drug. So that's something, it's just another thing to think about. So it's just another, the way I kind of describe it to my patients is like, it's just another arrow in your quiver. And these are just things you just play, and you want to just keep them out of trouble as long as you can. CRPC is the worst state because that's when all the promiscuous androgen receptors and all the stuff that Marty Gleave talks about that no one can understand. You just don't want to go in that, you just don't want to go down that rabbit hole. So whatever you do to keep them out of CRPC is good for the patient.
Andrew, sorry, go on, Jeff. I've interrupted you.
There was another very interesting study that will be presented, which is a PSMA first study that will be coming up this week as well at ESMO, with the use of obviously lutetium in a castration-sensitive setting, and that's a positive study according to the press release. So that's another quiver, I guess, using early.
So that's like that lunar study I was presenting that was presented at Astro. So we're again just another arrow in our quiver, which is another line of therapy. It kind of attacks the cancer in a different way. I kind of think it is like a boxing match, right? So if you're throwing a left and the cancer keeps blocking you got to come at it from the right.
And so, and along those lines, Andrew, have they, I mean, there have been lots of studies looking at what radiation can do to the immune response, right? And does that underpin some of the effect of adding metastasis-directed therapy to systemic treatment?
The abscopal.
The abscopal.
The holy ghost.
Well, I mean, this is what we looked at with lutetium PSMA as well, which is why I think that synergy is good.
Yeah.
Right, in combination. But what are your thoughts?
So I think when we've looked at it, this is like a mythologic kind of like
ChatGPT says this is a mythical
it's
creature.
kind of like a unicorn. Like we've seen it once kind of thing, and everyone swears they've seen it, right? But you actually look at the data, it's really hard to see. Louise Emmett did some really interesting work, and you can actually prime the cancer cells to make PSMA lutetium more receptive by maybe starting with an enzalutamide or something like that. So
yeah, we saw that work from Louise Emmett because the PSMA receptors are upregulated, and so you've got multiple sites now for lutetium PSMA
so
to
I
have
think
an
this
effect.
priming, I think that's the next stage is using the ARPI RNA to prime a lutetium intervention, and that's I'm so excited to learn more about this.
Wonderful. Well, let's cut to a few questions. But before we do, you mentioned PSMA edition, which reads out on Sunday at ESMO in the presidential. But we actually recorded a podcast today with Scott Tagawa, who's reading it out, and Michael Hoffman. So the data is all embargoed. But if you tune into GUcast on Sunday night, we've got the full thing. Yeah, and
I'll be there.
It's embargoed.
I'll be there.
Yeah, you'll be there on a flight somewhere. Yeah. Okay, a few questions. Thank you to everyone who's enthusiastically sending questions. Carlos Delgado had asked one earlier about positive surgical margins with BCR. Okay, so you got BCR, but you've got positive surgical margins. So I suppose that's a clue. Maybe the cancer is going to be down there at the margin. But even if the PSA is slower, if it's longer than 12 months, should that be managed as high risk? Well, I think that's the answer to the question. If the PSA doubling time is longer, like more than a year,
I think that's a perfect salvage radiotherapy.
Absolutely.
I think that just tells you that a slow doubling time, and especially in the context of a positive margin, you're talking about local disease.
Yeah, high chance of getting cure with a second.
Because EMBARK was really about identifying a subgroup of patients at high risk of metastasis, right? And so this is like the other end, right? This is the group of patients that very likely has local disease and very likely is cured with radiotherapy. Probably just, you guys don't do 20 treatments, we do 20 treatments, and we're actually moving to SBRT post-op. So 5 treatments is kind of.
Yeah, but that's a very important question from Carlos, because that, when you think BCR, as I tried to set out at the start, you have to separate out the patients who are going to be candidates for systemic therapy, and now we've learned tonight about the intensification of that systemic therapy. But don't forget about the patients who can be so-called salvaged with local therapy, especially, I suppose, radiation after surgery. So, Carlos, I think that's the answer. If that doubling time is more than 12 months, and so you should be treating this as EAU, BCR, not EMBARK. Vinod has asked a question for a patient who has had a radical prostatectomy and BCR, and he's had radiotherapy. So he's had the 2 local treatments to the pelvis. What's your approach? I'll ask you this, Andrew, to adjuvant ADT. So I suppose this is about the use of ADT following salvage radiotherapy. Actually, we discussed this on our podcast with you, and we these 3 things I asked questions about. One was, come on, tell us about the timing of ADT with and without a prostate in situ. So that's what Vinod is asking. And then how do you interpret the PSA? I suppose the question is, okay, they're on ADT as well. The PSA has gone right down. You don't really know for a year or 2 potentially if they're going to have more BCR.
Yeah, so I think before EMBARK, it was my approach was intermittent androgen blockade. That was something Canadians kind of were championing, and we bought very deeply into that story. And things have changed after EMBARK, right? Now we have, like, if you get a high risk BCR patient, we're now seeing a metastasis-free survival advantage, and apparently press release overall survival advantage. I think you gotta get the drug in early, and that you're actually you're separating those Kaplan-Meier curves over time. And so maybe earlier the better. And so it's maybe when 1.5 or 2, maybe we don't want to wait. We don't want to talk about the Phoenix definition. Maybe we should redo the Phoenix definition.
Yeah, we talk about that all the time.
We do,
our research
absolutely.
Meeting, another one, Jonathan Wallbaum. We kind of answered this a bit already, I think, Jeff, but he's asking about the other ARPs. Are we going to see results with other ARPs in this setting? Are there other EMBARK-like trials going on with the other ARPs? Do you know? I don't know the answer to that question.
No, I don't know if there's any other trials in this setting. But what's going to be interesting is bringing forward things like PARP inhibitors into that setting as well, particularly if they are sort of BRCA positive or HRD positive. So a question, I guess, for the panel is, do you think that HRD BRCA testing is going to come forward to the time of diagnosis of prostate cancer when you do your biopsies and all that stuff?
I'd be interested to see how you guys do it. If they have high risk features at diagnosis, we automatically do gene testing. And then if they fail and they have METs, that's another indication for testing as well. And so there's, again, more data coming out at ESMO. Very exciting ESMO this year.
It is, isn't it? For GU, for sure.
Very good. An anonymous one, Jeff, for you, who is too old or unwell for an ARPI? That's a hard question.
That's a great question.
Who's unsuitable?
Who's unsuitable?
Who's unsuitable for an ARPI?
Ageist or unwell list.
Yeah.
No, I guess if you're in a nursing home and can't swallow a tablet because of risk of aspiration, then they're not suitable.
But they can still get ADT. Good one.
Yeah. Exactly.
The oldest patient that I've given an ARPI to is a a war veteran, 102 years old.
Oh, wow.
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 If you've survived 2 world wars, you can have an
You
RP.
can
Yeah.
get through
You can have
angioedema.
an RP, that's right. But unfortunately, he had very aggressive disease and he just progressed through that. But that said, I've got patients who can't, whether it's psychologically or physically, can't swallow a tablet. The RP that you can actually dissolve in water or solution is actually apalutamide, and you can dissolve
I
it.
didn't know
that.
I didn't know.
Yeah, you can dissolve it in a solution and then swallow it.
Put it in a beer.
Okay. There you go.
Yeah, maybe you can mix it with beer. I'm not sure, but we have to ask the
Now
pharmacist.
we have a few cases we're going to get through because we got some polls. So I'm going to hold those other questions and see can we get through. But can we bring the slides back up on the screen? Keep Jeff there, Chetna, and we're going to challenge the panel with a few cases we're going to discuss and see can we learn from what we've heard already and maybe have a bit of controversy. So here's a chap, a 66-year-old. So mHSPC, more so this one. He's very fit. Now, he had very nasty prostate cancer 5 years ago. He had a prostatectomy, grade group 5, positive margin, had a persistent PSA, I think, at the time. So had salvage radiotherapy and ADT. Yeah, his PSA was around, I think, 1.3 when all of that happened. His PSA went right down with his ADT as well. But now he's coming off and his PSA is 0.3. Okay, so he's had surgery, he's had radiotherapy. His PSA was 0.3 mid-year last year. So his doubling time is only 12 months. But he went and had a PSMA PET CT. I personally would not have done a PSMA PET CT. Exactly. So this
Don't
part of
you
the
only get two? Don't you only get two?
Two in your lifetime,
like publicly.
Yeah.
Yeah.
Funded, yeah.
Yes, you have to pick carefully,
Oh,
But
that's a few
anyway,
things.
he went and saw he went and saw a GU medical oncologist, and
That's why.
that's why.
It's trouble.
That's why.
It's trouble. Always trouble. Except Jeff. Except Jeff.
Not Jeff. So he's had a PET scan with a PSA 0.3, and his PET scan is showing that he's got a 4 millimeter lung nodule that's on the screen there, and he's also got this tiny thing in T12 with an SUVX 4.5 in high quality, total body PET CT. So now he's been reported as this. So here's my polling question. So Chetna, let's open the poll because I want to ask, the panel, and I want to ask the audience as well. The first question is, well, what is the stage of this patient now? Is this BCR? And now his PSA, which type of BCR we can dive into, but his PSA doubling time is like 12 months. Or is this mHSPC, with a PSA of 0.3 or thereabouts? Because the answer to that question is going to determine how you're going to advise this man and how you're going to manage him. But so there's a lag while the poll goes up. I think it takes 30 or 40 seconds while that happens. But whenever Chetna is ready, she'll be bringing up this polling. Where's my polling tab? I think we should have a polling tab here when the polls come up. Here we go. Yeah, polling tab. First results will come in 45 seconds. So let's have a look at this one. Answers are coming in. So people are voting for mHSPC at the moment. While that ticks over.
Does it tell you how many people have voted?
64 viewers. So presuming that.
Say how many have voted?
Have they all
Tell us,
voted?
are you voting? Are people actually voting?
One of one says MHSPC.
Oh, okay.
Jeff voted for mHSPC already. What do we get votes on this? I'm not sure. It says it's live, doesn't it? So Andrew, what's your thoughts? First of all, it's like if you pull up on the side of a country road in Ireland looking for directions and you say, sorry, sir, how do I get to Johnny Malone's pub? And they'll say, well, I wouldn't start from here if I were you. That's kind of where we are. We've done a PET scan now. I wouldn't start from here. I wouldn't have done it. I would have see you in 6 months.
So I think this patient actually has metastatic disease. We struggle about this all the time in our multidisciplinary tumor wards, and we've kind of landed on the fact that if you can see it, you're just seeing it earlier, but it's real. And so we would probably manage this guy with systemic. So we try to get him on trial first. But if not, we would offer him metastasis-directed therapy to the lymph node, to that bone met and the lung lesion, and we'd probably put him on 6 months of ADT. And if he was on trial, we'd also give systemic intensification on top.
What do you think, Renu? You're still the one who have done the PET scan.
Yeah, I wouldn't have started from here.
Yeah, exactly.
That's right. But, I mean, it's, you know, I don't think the uptake in these lesions is that impressive.
No. Is it a ganglion?
It
looks like a ganglion. It's like right beside the.
Right.
I want Hoffman to read that out.
Well, yeah. But if you were, I mean, if this patient had a fast PSA doubling time, then I would say this is metastatic disease. Let's get doublet treatment, right? But
exactly. And he does.
problem.
So you're trying to correlate, aren't you?
You're trying to make it fit your desired outcome.
The voting, by the way,
So
is
I
saying
think this is a scenario that will
But maybe
expose
you've got
your
benign
biases.
disease where you radiate it and it goes away forever, and then we get the win.
96% mHSPC.
It's an academic exercise.
Jeff, what's your vote on this?
Yeah, I think so, but I wouldn't sort of. We'll talk about this at an MDT, but you know, I think if it's well and asymptomatic, I think we can afford to watch for a little while, do another scan a bit down the track, really. I mean,
well, that takes us to the question. So Chet, now please open the next poll. So I mean, it is what it is. You have a choice now of managing it however way you want, and let's pretend we have an embark era. So number one, are you going to just watch him? He's come to you now for an opinion, for example, and say, well, what would you do now? Now, I want you to say he's a commercial pilot, so he's an extremely senior pilot. He's now a training captain. So all he does is train pilots on the really big jets. So it's like, and as you well know, if you deal with CASA and the aviation people, like they're very strict on this. So that's why he'd gone for a few opinions before we even saw him. So that bearing in mind, he absolutely wants to try and keep his license. So it gets a bit complicated. So what would you do though? Number one, just keep an eye on him. Number two, ADT alone. Number three, ADT plus an RP. So I haven't specified whether you're treating him as like embark or he's not embark. He wouldn't meet the criteria.
No, it's not.
I put the RP alone one in because that was an option in embark. So I hope not too many people don't vote for RP alone because it's not actually registered for.
Why didn't you put triplet therapy in there, Declan?
Back to what's wrong with me? You know, we have a
What's wrong with you?
Or stereotactic radiotherapy.
Here's some votes. Our stereotactic. So we got some votes coming in, and then we'll ask the panel their thoughts. So 20% say observe, 0% say ADT monotherapy, 50% say ADT and an RP. RP alone, okay, it was a bit of a furphy, but I like the enthusiasm. Jeff, what do you think about this? I think you said a minute ago. Did you
already
observe
say,
him?
yeah.
He's a pilot, right? I mean, if he wants to maintain his license, I like Andrew's approach. You know, just savor the spots and bring his PSA down and give some ADT, which hopefully shouldn't affect his
short term, like 4 to 6 months.
attention. Yeah,
That's why it matters so much what you call this. I mean, if you label him with metastatic disease, then yeah, for the sake of his profession, he probably needs to have some treatment, right?
Well, I'll tell you what happened. But you could saber these things, could you? What about that 4 millimeter Roger? You never see that thing, will you?
We would be hard pressed to find it, but we could.
Yeah.
We'll fuse the imagings together, and then so you can see it on a CT scan. We do an MRI to try and identify it. Oftentimes, when you see something on the PSMA scan and you do an MRI, you squint really hard, you can actually see something. So.
Yeah.
So he was managed with what half the panel said. He was managed with ADT and an RP. So he was managed with ADT and darolutamide. And this is pre-Aranote, interestingly. But we have a peculiar situation in Australia where we've been able to use ADT, darolutamide as a doublet, if we wish, off-label and funded. Since 2023 So quite a lot of people.
Does Darrow affect his license? Like, is that considered?
Well, that's what comes into it. So he did, and obviously the PSA went from 0.3 to
0,
less than 0.1. But he had issues with his pilot's license because they said, we need a letter from your oncologist. So the oncologist wrote to the CASA, they're called, and he said, I'll put him on this, and he sent them a copy of the Arisens trial,
right?
Triplet therapy trial.
Yeah, Arisens.
And then they took one look at that and said, okay, that's it, you can't fly anymore. Because they looked at the event rate in Arisens.
Right.
And for them, they have these criteria, it's all about event rate. And and then he came to me for a second opinion. So he said, I've lost my license. And I said, well, they were all down the wrong road completely because I said, well, first of all, he's nothing like any of those patients in Arisens. Like, you're not eligible for the Arisens trial. Yeah. They're all terrible metastatic prostate cancer.
And polymetastatic.
Their PSA is like 15, 16 when you win, and they do well on triplet therapy and so on.
And de novo patients. Like,
So I had to go back in time and say, the most appropriate data set to look at would be the Embark patient, and he wouldn't even qualify for the Embark trial.
Right.
So I said, that's the event thing. So we convinced them, and so he got his license back. But I'm kind of treating it, I'm doing conventional imaging every 3 months, no more PET imaging. And he's not like, he's going great, but I think it just shows you, this is his question, can I stop treatment? And so I've now offered him to stop treatment, and I had a conference with the CASA people. I do a lot of these pilot ones, and they know me well, and they said, "No, this sounds very reasonable." So I keep them updated. But now, we're into the kind of, well, if he was bad enough to get into Embark, and he's not even, would you do intermittent doublet? So Jeff, I don't know what it's back to that intermittent doublet question again.
I would, because he's a pilot, and I don't want him to be falling asleep while flying a plane or landing. So yes, if he was my pilot, I want him to be on intermittent and hopefully off ADT and Daro when he's flying. So yes, intermittent's my choice. And also he probably kind of meets the Embark criteria for, reaching less than 0.2 in a short time,
Yeah, fair enough. And I offered it to him, but on the other hand, with him, he said, "Look, the most important thing, I want to keep my license." So, and he's doing very well on ADT and darolutamide, having minimal symptoms. So, yeah, but a classic conundrum, isn't it? And this is what's the problem with this case? It's the freaking novel imaging, isn't it? And he was going into head for systemic therapy, wasn't he? Nasty cancer originally, did pretty well with local treatment. Exactly. And his doubling time will take off, and then you're into the options. But
horrible. But he'll get years, especially if he had stereotactic radiotherapy to consolidate that. Like I said, the data that we showed, like, and if you're talking about doublet plus metastasis directed therapy, I've had guys go 10 and 12 years with meds. Just on ADT and stereotactic radiotherapy alone.
We've got about 8 minutes left. So what I'm going to do is one or two more questions and then maybe one more case. Francesco Alvarez asks about triplet therapy, Jeff. So given the incremental survival benefit, but much higher cost of triplet therapy, I presume he's meaning like with chemo. What are your thoughts on real world cost effectiveness and accessibility, particularly in like middle income settings? So given the incremental survival benefits, now I'm going to trot out my usual line of there's no evidence that adding docetaxel to ADT and an ARPI improves survival, and it definitely decreases quality of life. And Francisco's asking about the cost as well. So your general thoughts on triplet therapy, I suppose.
Well, I suppose, in Australia where we've got a funded health system, and so adding docetaxel, as you know, the drug itself is very cheap. But the cost comes with, having to give chemotherapy to a patient in a day unit, there's a cost involved. If they get neutropenic, there's a cost involved in admitting the patient for antibiotics for 3 or 4 days. But in general, I think I discussed the data, and it's quite difficult. If someone came in with high volume, almost like a super scan, like, disease everywhere, I would definitely think about a triplet, because I think when someone who's young with a lot of disease, debulking the disease with chemotherapy and bring the PSA down quickly is a benefit. As we know, you can get the PSA down to less than 0.2 in 6 months. They're going to do better. So that's my aim: get the PSA down to 0.2, no matter what and no matter how. So triplet is the quickest and fastest way of getting the PSA down to less than 0.2 in 6 months.
I must just say, some of you might have heard a dog howling there in the background. That's my dog Hamish, and if someone talks about docetaxel and triplet therapy, he howls.
He starts barking.
He's torturing him.
He doesn't like it, is it?
It's true. Hamish doesn't like this docetaxel.
Look,
No. Hamish rubs off on you and you say you don't like docetaxel, but
Honestly,
it's actually
the pair
Hamish.
of us sit here in the evenings talking about how terrible triplet therapy is.
I don't give it to octogenarians lightly. I never do, the old people.
Okay. I'm not sure we have a couple of more great questions. Renu, this is about the definition of oligometastatic disease. You and Andrew might deal with this. Abdullah asks, like, the definitions vary from 1 to 3 to 5 to 10, PET imaging, novel imaging. Should there be some sort of more biological description of oligometastatic rather than counting numbers on scans? So,
Yeah, I don't know the answer to that. I mean, this is true. This is a bit of a dilemma that we face. Depends on what kind of imaging modality we use, and and if it's PSMA PET, some are more avid than others. Is that one a mesh? Is that one a ganglion? It's very hard to know.
And also it depends on bulk too. Like, you can have a single lesion that's 20 centimeters long. It could be an entire parataric region, right? And it's still one.
Yeah.
Or it's one confluent met, right? So I think we're going to get better. I think we'll probably start to think about like volume of these mets. But the only way you can the way I approach it is just because the way the trials have been defined, it's generally 1 to 5 mets is considered oligometastatic, and we're generally talking about counting individual lesions. Like if you have 2 lesions kissing, we generally consider that 1 lesion, but it's kind of like up to 5 discrete lesions. And there's good work actually out of the Stampede data showing that as the number of mets goes up, the chance of disease control goes down. So prognosis is way better with 1, slightly worse with 2, and then it just goes downhill from there. So.
Very good.
All the way down to triple therapy.
Chetney, you can take down those slides, and we're going to be finishing up in a moment. A couple of more quick questions, but we won't get into the cases because we want to finish on time. Give people back their evenings. David Hennies is saying, thanks for the great talks. Thank you, David. What about selecting patients from, this is about lutetium PSMA, this is about the LUNAR and PopStar-2, I suppose. What clinical markers or what criteria should help us guide those patients who might benefit from adding lutetium into SBRT? Is it the site, the number, the PSA, the signature on a PET scan?
Yeah, all good questions. So I think, for those trials, it was basically you had to have oligometastatic disease in LUNAR, and I think PopStar it's up to 5, if I remember correctly. And then it's, I think PopStar is like a sandwich therapy. I believe it's one, then the SBRT, then another. LUNAR gave both neoadjuvantly. It's a different ways to slice the bread, but it still tastes good at the end of the day. And I think we'll just figure out more. Like I said, these are small trials, and they're basically just showing us exciting signals that tells us to keep going down this pathway where we eventually have to do the proper randomized studies. Problem is, I think, that the systemic therapy recipe continuously changes. And so for us to mount a phase 3 study, it's going to be, by the time it actually reads out, it'll be totally different. So I don't know what to do, but that's our job as academics.
Yeah, that's becoming a real problem now in prostate cancer.
It's a good problem to have.
It's a good problem to have.
We only had one arrow, right?
Yeah.
From systemic therapy. It was like we had ADT, and then we had melphalan, and prednisone. Way back then, remember that?
No.
Oh. Wow, I'm predating you guys.
Sorry, he's older than me. Is he?
Okay. And Joseph Apple came out in 2004. Anyways, so we it's nice to have a couple of things we can play at.
Yeah, absolutely.
And we're nearly done. And by the way, on that LUNAR type PSMA thing, we do have Amar Kishan here in the studio next Tuesday.
Oh, amazing.
Yeah.
Oh, great.
More radiation. The annual.
Oh yeah, he's coming for
the meeting. So Wee Yong is coming out here. And Amar is our radiation oncology associate editor on European urology, where we work as well.
Smart man.
He's a great guy, yes, but he read out that trial at Astra, so we're going to have him here in the studio talking about it next week.
I'll be tuning in.
Jeff, one more question I'll throw at you from Abdullah. How many metastases are too many? It's flowing off the back of this question about it. I'll put it out to say, Andrew's going to say there are 19 PSMA avid metastases on that scan. I can get them all with my guns and arrows and all that sort of stuff. They're all, I can get them all. But you might have to be at the tumor board to say, stop the nonsense. Stop the nonsense. We're drawing a line under that 14 or whatever.
We'll start with the definition of oligometastatic, isn't it? It's 5 or less. So let's stick with that.
Well, sometimes we go up to 10, right? So there's a Comet 10 study. So like we've had that. And I think it's feasible. The issue is that the more volume of tissue that you radiate, that basically you're going to start influencing the marrow, and that may be bad for patients who need chemotherapy down the line. So that's our trade-off, I think. So radiotherapy it's not, it's generally well tolerated. There are bone fractures and things like that if we treat the bones and stuff like that. But you have to think about the marrow in the end of the day. So I like 5. I think 5. 5 to 10 is, to me, it's the gray zone. So I'm solidly under 5. 5 to 10, I'm like, show me the data. Some of my CNS guys give gamma knife to like 45, 50 brain metastasis. So we're not as crazy as some of the oncologists out there, but I'm not saying it's right. I'm just saying what's happening.
Yeah,
I suppose brain mets and bone marrow is slightly different, and I totally agree with that. For the fact that you got to leave us some room for some chemo later on. And even some room for lutetium or actinium, because they also destroy marrow.
So I like 5 or less. Me personally, I like 5 or less, but I'm willing to put patients on trial and do the 5 to 10, but in a trial setting.
So in the high volume setting, oh sorry, you guys finish off. It's time.
It's time. The whistle's
He's
got
called
blown.
it. He's called it.
Yeah, Renu's giving me a dig, saying that's it. Come
Yeah.
on.
Yeah.
That was enjoyable.
It was very good. It was
And
fun. I
despite
learned a
the-
lot.
Despite
And as
that
ever,
on being here.
I learned a lot
Despite
from
that.
our multidisciplinary colleagues. Well, look, and I'm sorry we didn't get to all of the questions. Thank you so much to everyone who did fire in loads of questions and vote in our polls. They were really good questions. I think they reflected real life scenarios. That's what I really liked about them. And look, yeah, thanks so much to the audience for, of course, for dialing in, and thanks so much to Andrew for popping back into the
Thanks for
studio
having me.
again, back for more.
I'll be back again.
This
if you
won't be
invite
the
me.
last time. Yeah.
won't
Oh, I would
absolutely.
love to come back.
Yeah, absolutely. You're great on a podcast, so we'll be dialing into you more often. Thanks very much to Jeff in Queensland for dialing in as well and for updating us on those trials and little sneak peeks into what's coming just this week. ESMO, really big
Exciting
meeting
stuff.
in Berlin.
Big meeting.
And finally, thanks very much to the team at Mundipharma, to Louise and Amber for putting all this together and for being great supporters of us here at GUcast. We will be pushing this out as a podcast, so some of you are accessing this as a podcast as well. And finally, to the team at Spot Me, who did all the technical work in the background, Chetna and Rob and everyone else. So that's all we have time for. We wish you all a very good evening, and thanks very much for joining us. And we wish you, thank you.
See you next
Yeah,
time.
thank you. See you next time. Bye bye.